Kia ora koutou. Welcome everyone to our lunchtime webinar for October. We didn't have one last month as there was industrial action taking place, but today we're all here, which is fantastic, and I'm very pleased to welcome both Sarah Campion and Jules Smith. They've been working on this project together, and they're both going to talk about debriefing critical incidents. Just a wee introduction to Sarah. Sarah's the Restraint Elimination Coordinator who works in the the Practice Development Unit. She's also the co-chair of the Southern District Debriefing Operational Group. And Sarah says debriefing is part of our organisation's responsibilities under the Ngā Paerewa Health and Disability Standard 2021. Jules, sitting beside Sarah, is the Resus coordinator in the Practice Development Unit, and you both have worked together on this debriefing project thus far. I know it's got a future possibly as well. So thank you very much, and we look forward to hearing from you. Kia ora.
Kia ora. Thanks, Lorraine. Jules and I are both co-chairs of the Debriefing Operational Group, so it's lovely to meet you all, and thank you so much for the invitation, Lorraine. So over the past 2.5 years, Jules and I have been working together since we attended some training, some critical incident stress debriefing training through the Crisis Intervention and Management Australasia, and we reflected together and we noted that there was a lot of significant gaps, and we developed a district-wide debriefing operational group, and we then started developing a protocol or a process that we could encourage staff to be following. Today, we just would like to share some of the progress that we've made in terms of our educational program and where we want to, where we're heading the organisation, where we're actually wanting to head to improve the psychological safety of our organisation.
So you'll notice one thing that Lorraine had said was, this is around critical incidences. So just talking around what is a critical incident to start with. So we've got all the obvious things like cardiac arrest, restraint, emergency intubation, managing an aggressive patient or indeed anybody aggressive, major bleed, respiratory arrests, anaphylaxis, and those are all big exciting things. It can also just be anything scary, so anything big and new and daunting that you've done for the first time. It can even be, a really busy crazy shift. So we've worked with the Health New Zealand definition of a critical event taken from World Health Organization, which is an event out of the range of normal experience, which can be sudden, unexpected, include elements of physical and emotional loss, something that is distressing and confronting for ourselves, which challenges our own capacity to cope. So really important that as carers that we're also caring for ourselves, so that we can be restoring each other's taha hinengaro and mana. So normal, what is normal, what is abnormal? Honestly, it took me a long time to really realise that as a nurse, my normal day is everyone else's abnormal day. And especially as an ED nurse, as a PAR nurse, I wasn't just seeing people when they were having their elective surgery that they really wanted. I was seeing people when things started going wrong. And yeah, often, the worst day of their week, their year, their month, their decade, their life. And so our own sense of normal is often quite skewed as clinical staff members. So really it's thinking around things like not normalising the abnormal. And you've probably all been there when a colleague has said something like, oh, that's the first time I've had to use a crash trolley for real. Or that's the first time I've had to send somebody to ICU. Something that can be quite normal for you can still be a big deal for our colleagues. So we're just trying to sort of have a little bit of discussion around what's normal, what's critical incident, what is abnormal, what is normal. And just trying to keep that net quite wide so that people have the opportunity to speak up and say, actually, for me, this was critical, this was not normal. because we're aware that if we're using the Te Whare Tapawhā model, that our wellness is more than just our physical body, it is our emotional state, our family, our community, our psychosocial as well, and a critical incident is anything that can derail any one of those walls.
You'll see a wee picture there of Iron Man, and we all come with our armour. It's a great analogy to explain how it is that actually underneath all that armour, we're actually all that a human underneath all that. And when we come across that critical incident, it's either sometimes we're functioning in a place where that we might manage that and be functioning at our full capacity. But when a critical incident comes along, it can become unmanageable. And that's when it sometimes flicks into this a crisis functioning, or you're either functioning with an impaired capacity. Do you want to add anything else to that?
I don't think so. I think it's sort of about opening it up to the team as well. So something that you're quite used to managing, and you're finding yourself in the green zone here. For the new grad, they might be fully in the red zone. So just about sort of having that conversation, how do we all feel about this? And if everybody feels fine, that's great.
So just to give you a little bit more background, I've got a wee kind of display there. So as you sit there, I want you to imagine how well reinforced your own armour has become over the years of your clinical lived experience. But again, under that armour is a human, and a human who feels emotions like every other human. A human who, despite armour, is exposed to a critical event, which may manifest into what we call some psychological distress. And that's a state where thoughts and feelings our thoughts and feelings become disrupted, but the individual may still function. When distress increases, it can overwhelm our coping mechanisms, and it escalates into what we call a psychological crisis. And when you're experiencing that psychological crisis, our cognitive resources are effectively hijacked, and that comes along to can have a number of consequences attached to it. So we could have impaired decision making, we've got increased fatigue, and we've got that narrowed viewpoint. So our cognitive bandwidth is quite a lot reduced if we are operating in that sense of where we are hijacked and not thinking with our upper cortex.
I think, for clinical staff, that's so important because as shift workers, you're kind of used to dealing with more or less fatigue on any given day. But working in the complex environments that we work in, it's ideal if we have our full cognitive bandwidth firing. And of course, decisions is what is impacting our patients' care all the time. It's what drugs are we giving, what pain relief are we giving, decisions about, do I escalate this patient? Even just decisions about, am I happy with how this patient is looking, yes or no? Like we're making decisions all the time in health.
So just want to define what clinical debriefing is in our context. And I came across this lovely concept analysis, which was written by Towles et al. In 2020. And she defined what clinical debriefing, clinical debriefing was. So that's an ad hoc interprofessional structured gathering that occurs in the clinical setting after a critical event. And out of this, after she defined it, she developed a framework, and that's the 5 E's framework. And there are a lot of tools out there that have been used, but there was 5 critical elements which needs to be a part of any tool that you might use to help you facilitate a debrief. So what we know is that an experienced or educated facilitator needs to be present. So that's our champions, and that's why we're now delivering an education day, which is just 3 hours for our senior nurses to feel confident in being those facilitators. It involves the environment, ensuring that it is not only you don't have a physical place or private place that you can go to, but also looking at the psychological safety and hierarchy of the environment, the emotional side of things. And then there's education. So that's a little bit about your interprofessional learning. So that's sharing of knowledge within the team and growing your knowledge base. The fourth one is evaluation. So that kind of looks at our quality improvement processes. The situation happened and what can we learn from it? And emotions. And the emotions is one thing that's often overlooked in debriefing. Quite often it's focused on education and evaluation. And this framework in itself has been used as a tool, as a conceptual framework within when you look at other debriefing tools. So a systematic analysis by Phillips et al. Analysed many different tools out there, and they found most of them didn't actually meet the 5 E's. And there is lots of evidence now out there with the interprofessional learning part that and that interdisciplinary, as we gather in together, that this can also have a profound effect on reducing patient mortality and morbidity or adverse outcomes. In a recent meta-analysis by Webster et al.
Decent amount too, like we're talking a reduction of up to 25%. So that's huge. Yeah.
So it's it does the after event or immediate debrief provides that learning opportunity to get together and move forward with how can we improve or how can we prevent any further bad things from happening. So this, I did an integrative review in my last paper, which was the research methods paper. And one of the key things or the key themes that I noted that came out of that was that critical events that impact our staff wellbeing and structured debriefing supports the resilience and retention of our staff. So the key things that I found, if you want a successful debriefing program, is that if anything's going to happen, it needs to be short and doable within 5 to 10 minutes. It needs to be led and trained by facilitators that are familiar with the team dynamics or the unit dynamics. It needs to be safe and non-judgmental, space for reflection. So this is where our psychological safety kind of comes into play. And not finger pointing, or it's not a blame session, and it builds on that trusting relationship. It needs to have a balance between the clinical and emotional review when comparing different areas in like ICU versus ED. The ED staff wanted more of that clinical understanding of what happened, whereas staff in the ICU environment needed more of that emotional support. So it's about understanding that balance and what's important for that area. It also included having strong leadership, and it had to have some workflow integration. So there's lots of impacts that can come out of this as well. So it can improve your team communication and increase compassion satisfaction, enhance everyone's coping mechanisms, especially when you might, for example, have a new grad that may have just experienced this situation for the first time. It can help them learn and develop, and also it can contribute to potentially reducing burnout amongst staff.
So, often I think in the past debriefing has been more around clinical learnings. What did we do? What didn't we do? What did we do well? What did we not do well? But the literature is really pointing towards emotions needing to be a part of debriefing. So it's about restoring a person's whole self. I once heard something that said, that stress kind of runs downhill. So you're stressed, you go home, you yell at the kids, the kids yell at each other and then the baby kicks the cat. And so we kind of, it's, you know, it was one of those things that sort of stuck with me about, you know, we want to be well so that we can give good care, so that we can interact well with our colleagues. We don't want to be that sort of stressed, frazzled person that snaps at people and sort of destroys team harmony there. So it's about, you've been through something really stressful. It's just about taking 5 to have a bit of an emotional reset, to say, okay, that was, you know, a bit stressful. Let's all just come together, and how are we all feeling?
So there's a few different types of debriefing that occur within our clinical setting. The one that some people or most people might be most familiar with is the debriefing within simulation training, which has quite a different focus on the educational outcomes.
Yeah, so the simulation training, you know, you're talking about a quite controlled scenario with specified learning objectives. And then the debriefing in that case is around, you know, how were we with those clinical learning objectives? So, you know, how was our communication? Did we use closed loop? For example, you know, did we follow the algorithm? That's not necessarily helpful after people have just been through a fairly confronting event. So the critical event debriefing is more person-centered. It's more focused on that psychological well-being. So we've divided up into and really sort of separated out that hot or immediate debriefing, which is purely around that psychological well-being. The cold delayed debriefing, you know, that's often where you get some answers. And, you know, I am one of those ED nurses that Sarah mentioned, you know, we're dealing with mysteries, we like answers. And I know for me that when I've been involved in events, getting those answers is part of calming my farm, I guess. You know, it's part of giving me the answers so that I can settle down and say, well, okay, actually the patient was already dead. That was known, you know, had we known on arrival what we knew later, we would have known that we couldn't save them. And that's very reassuring to know that no matter what you did, you couldn't have changed the outcome. So emotions can be tied up in clinical data, and we appreciate that. And then if there's been any problems with, you know, equipment, systems, processes, then that gets put into an operational debrief, and that happens, you know, at an appropriate time. If there's a defib problem, you know, let's deal with that one right away. Sometimes we've got a little more time up our sleeves to deal with it. And again, it doesn't need to be the whole group. We don't need 20 people all reaching out to say, Jules, the defib didn't work. But, you know, we just sort of need to hand it on to the right person who can make it happen.
It can be used, operational debrief, in the restraint context, looking at our processes with, or meeting up with the security team, for example, and how we operate and call on their resources. So it looks at how we engage as a team in that sense. There's also purposeful or habitual debriefing that occurs, and again, that's an ad hoc sort of thing, and that can help just improve in performance. And that might be something like an operation. At the end of an operation, there is a debrief with the team, the anaesthetist, the doctor, and all the surgical team that were involved there. So debriefing doesn't necessarily have to occur immediately after a debrief. It just might be something, you know, that happens after the end of a shift, and gathering together to debrief what's occurred.
So you don't go home and kick the cat.
Yes, we don't.
So because this project was looking like it was gonna become completely enormous, we decided to start by focusing on that hot or that immediate debriefing, with the idea that the rest can follow later on. Currently, we're still just letting EAP, which is now TELUS, perform the cold debriefing, and the operational debriefings will hopefully be happening.
Yeah,
but
so
we wanted to really put our focus in on the one thing that can make the most difference for people.
It's about developing a model or sustainable model that everyone can adhere or achieve. So understanding the purpose and objectives. So a debrief doesn't have to occur only when a critical event occurs, like we just said. Debriefing provides us with that opportunity to learn and debrief. It can lighten your and your colleagues' mental load and address that immediate concern, which may distract us and prevent us from performing at our best. It leaves people with the impression that they're also not alone in their experience. Some events can have a profound effect on us. They go home with us and they can sit with us for quite some time. And it also, in doing this, it facilitates that normal recovery response, or that normal people in a small group who have that normal reaction to an abnormal event. So our program is not a substitute for any type of psychotherapy that one might receive as well. So when me and Jules did get together, we found that there was quite a few gaps, in particular within our legislation. So Health and Safety Work Act, which has been around for quite a long time, has a statement there in terms of our psychological safety of our mental health and our environment. So Health and Safety Work Act 2015 requires person conducting business will provide and maintain a work environment that is without risk to safety and health, including mental health, so far as reasonably possible. And when I read that for the first time, I sat there and I reflected, and I'm like, how psychologically healthy or safe is our environment when we're exposed to these events continuously? And it's about getting to back to a state of preparedness, or back to a baseline of your functioning. And what do we do in our environment to ensure that we are providing a healthy environment?
Obviously, in health, we can't stop those things happening. I mean, we do as much as we can, but it's about, what do we do to look after our staff when they have happened?
Yeah. So our organisation does have an obligation to ensure that. The other gaps that we noticed in lines within Aparua Health and Disability Health and Disability Standard 2021, which we were first audited and had a certification against last year. So there's two outcomes in particular which pertain to debriefing, and that is 2.4.7, healthcare and workforce and support workers shall have the opportunity to be involved in a debrief and discuss and receive support following incidents to ensure well-being. And then we've got 6.2.8, which links in with restraint. So healthcare and support workers shall have the opportunity to be involved in a timely debriefing following a seclusion or restraint event. So this picture here, you may not be able to see it on the screen, is just to kind of show you what we've been working on. And so critical incident debriefs, we've been focusing mainly on the staff, the staff side of things, but there is another side to this, and that is looking at debriefing with our patients or our families, and that comes into the restorative responses, because it is the outset, or when that critical event happens, that is the first opportunity that we have to restore that relationship if there has been harm that's occurred. But that is for a 2026 project, so we are focusing in on the staff. So that's just how big the process is looking presently. So bringing it down to this protocol that we've developed, you'll see at the top there that you've got the critical incident. So that could be a number of things. It could be a cardiac arrest, it could be a restraint intervention, it could be a horrible shift that was understaffed, it could be a patient behaviour. So after that critical incident, if you, with a facilitator, you'll have a group gather together for a hot debrief. So we want that to happen as soon as possible. And that's aiming at having that brief check-in or that psychological well-being of the staff that have been involved. And there's a number of tools that we've got in the education program that you can use. Within that hot debrief, we do ask if you identify the need for a cold debrief. So was this event so significantly harmful that we actually need to gather back together? So if that's the case, then the SCNM needs to be notified, and they can do a referral to TELUS Health for a cold debrief to be facilitated by one of their staff. Now, the hot and the cold debrief are both very wellness focused, and if there is operational issues that are arising through these things, then that needs to be taken off out of that conversation and addressed in a different forum. And as we work down through this process, depending on where it's ending, it might end after the hot debrief, and then it takes us back up to the state of preparedness. So ready to be prepared for the next event. So that might be through education and simulation, policy and procedures, and safety hurdles.
So yeah, just sort of really that focus on hot debriefing is around staff getting closure, support, care, love, a bit of teamwork, restoring that psychological well-being. And we have just cast that net pretty wide, so it's around any critical event that's causing distress, and it is for everybody involved, so including your HCAs, security, orderlies, any of those support staff who could be around. And then we're really wanting this to be, you know, a meaningful thing that really helps people. So it's not just about ticking a box so that we meet the law. It's not a review of anybody's practice. It's not providing gossip for the rumour mill. But nor is it professional counselling or psychotherapy. So if you want to become a hot debriefer, you're not, you know, we're not expecting too much of you. So we've been training nurses in becoming hot debriefing champions. So some of the parting have been through, and we piloted in 7th floor, 8 med and ICU. And so really at this stage, it's around supporting those staff as they're running the debriefs, and then over the next sort of 15 months, we'll be rolling it out around the rest of the hospital as well. So if you do want to be trained as a hot debriefer, have a chat with your manager and flick us an email, and we'll get you onto a session.
So we would like to open to the group if you have any questions. I'm just not sure how to do this on Zoom.
So mostly, and kia ora anyway, tēnā korua, that was just fantastic. But I'll close in a while. We'll just ask for questions now and comments. There is one already for both of you. From Glenda Maxwell, are the 3-hour workshops available to rural hospitals, or are they all in-house?
We have been to Oamaru, so if a rural hospital was wanting, we would just come down if that suited.
Should they contact you?
Yeah. Come get in contact with us and we can arrange a date. The idea around the education program is that especially for other remote hospitals, is that they can take our package and then use that package of education to then deliver that training within your areas. This is just the starting point for it, but we have been up to Oamaru and spent some time up there with the educator up there, and hopefully they will just keep that. It's supposed to be a sustainable model. Hope that answers your question. Get in contact with us.
Yep, that sounds great. Does anyone else have any questions to put in the question and answer or into the chat for Sarah and Jules? Just while we're waiting, maybe that was just really good, really fantastic, and you've actually put together, you can't see it, sorry, a booklet, haven't you, on hot debriefing champion training? Is is that the manual for the training session?
Yes, so
Okay.
each of the participants will get their own manual.
Yeah. Where are they
which-
advertised, the training sessions?
So they haven't been loaded on Employ Connect for next year yet, but they will be coming up soon. I've just finished the ad for the education booklet. But anyone's welcome. We do recommend that it's not necessarily for a new staff member, it's actually for senior nurses in particular who are ready to kind of make that leadership jump.
Okay. I've just got another question. Well, it's actually a comment from Karen Faraccioli is saying that Oamaru is HSS, so health services, but Gore is not. Do you provide to rural hospitals who are under commissioning? So not part of the HSS, part of Health New Zealand?
We haven't spoken about it, but like we're probably.
No, we're going down to Queenstown at the end of this year, and that's at their Health NZ. So I don't see that it would be an issue. I think we need to probably have a bit of an offline discussion with our manager, Bron.
That's right. Take it to your line manager and
if there's a demand for it, certainly. I don't see the harm. I'm more about sharing the love than keeping it.
That's great. And I think if the rural areas are interested, the first step for them would be to get in touch with you, and then you can have those discussions. There's another comment here from Lucy Prinsloo. Thank you for the amazing presentation and what you offer for all staff. This is such an important part of any major clinical event. And I would have to echo that. It was really good presentation, and even right from the beginning I liked what you said about defining a critical event. For one person it might be an everyday thing, for another, particularly new grad or someone new to the area from another country or whatever, it could be huge. So no assumptions, and
it's meant to be inclusive, Lorraine. Like it's supposed to involve everyone in the event, so that includes your healthcare assistants, your security staff, your orderlies. It could be that, so it involves everyone, just to make sure that they're actually okay. It's more about giving everyone a big hug, but also using some type of structure to that conversation that can occur immediately afterwards.
And certainly the operational type you talked about, there might be things that need to be done in the future too.
Yes, because quite often what I've seen is that a debrief following it ends up being quite operational, and it takes away from that emotional focus, but we're all human. And we can't argue or not acknowledge that human part of us all, and when we go back home, that emotion comes with us.
Thank you so much, Sarah, and to Jules, who's had to go to another meeting. People can get in touch with you, so that's fantastic, and it'll be really interesting to see where this goes.